So the aim of the game for me is to basically just give you a taster of what life as a cardiovascular radiologist is. That's the one. So we'll start with the pros of a career in cardiac imaging. There are many. For me, it's a very varied and interesting and exciting specialty. That scanogram on the left there that you can see is from a CT I was asked to report during my third year registrar training in a trauma center, and you can see there's a carving knife going directly into the sternum there. So, you know, those are the things that are really going to wake you up at 3 in the morning. It's complicated acquisitions often, it's complicated images often, and it's complicated patients. But if you're the type of person who enjoys knowing a lot about a little, then this may be for you. There's lots at stake. You know, it may not be such a problem if you miss an adrenal nodule, but if you miss, you know, aortic extravasation, that could be the difference between life and death, as we'll see in a few slides. And so it's a really interesting specialty to be part of. I'm not really going to talk much about thoracics because I'm much more cardiovascular than thoracics. But this is really just to give you a little flavor about a niche specialty like this. The rapport with clinicians is what really keeps me going. I would say that the job is all about the interface you have with the other people in your multidisciplinary team. And cardiovascular radiology is a prime example of that because it's quite often shared with cardiologists, and you will be talking to cardiothoracic surgeons a lot. It's a bit different to other subspecialties in radiology in that it's very patient-facing, and I think it's the future. There's so many opportunities in research and teaching and leadership and management, etc. So if we move on now to the cons, it can be difficult to gain exposure to cardiothoracic imaging, particularly cardiovascular imaging during training. You may have to seek it out. I had to fight for some of the things that weren't sort of standard curriculum topics like nuclear cardiac imaging. And then this isn't really a con, but it's just kind of the way things are, is that some people are much more cardiac than thoracic, and some people are more thoracic than cardiac. And a lot of the time, even if you want to go 50-50 in your life, a lot of the time you will end up being either big C, little t, or big T, little c. Cardiology versus radiology, that is a long-standing issue in many places because the cardiologists can report cardiac imaging scans. I would say it's much less of a problem these days because the volume of work is so high that now really it's a bit antiquated to think that you cannot just share all of this work. And I find it goes much better if that's your approach. And I've not really had a problem with that, to be honest. You will end up in a large teaching hospital if you pursue a cardiac imaging route, mostly because that is where cardiac centers tend to be, cardiology, cardiothoracic surgery, and then very few places in the country will have things like transplant, etc. So they tend to be big teaching hospitals. If you do thoracic, it's a bit of a different story, but for cardiac, that's certainly the case. There may be more exams, particularly if you have to accredit the same way as a cardiologist would. So there may be some more exams and accreditation and paperwork in the future. Yes, and often they're long scans. A whole aorta could take up to an hour. TAVI scans can take up to an hour. So those are not sort of the fast turnover type specialties. Okay, so here we've got a typical day or week. This, I have to admit, this was the case for my previous job at St Thomas's. I'm now at Royal Papworth, but you know, you'll have variations on the theme with some general sessions scattered throughout your week, and then you'll have either a lot of lung stuff or a lot of cardiac stuff, and it depends really what you go into. Next slide, please. So some of the cardiac MDT lists could be in structural cardiology, an intervention. You could be advising like a roadmap for their procedures because they're not done open, so you have to kind of do all the planning beforehand. Congenital heart disease, which is one of my main interests, very interesting meeting. Infective endocarditis, and not all hospitals will have all of these, but for example, there's always an ischemia or a coronary meeting. And then I've put pulmonary hypertension meetings in brackets there because that could be seen as either thoracic or cardiac. Next slide, please. Okay, so why don't we go through a few different modalities. So coronary CT, this is what it would look like if you get it right. And you'll have seen the patient here, and you'll have spoken to them, taken a history, looked at their ECG, so it's a lot more hands-on. And you want to get it just right. You need to put the ECG leads on. Well, the radiographers tend to do that, and align your scan with the patient's heart rate. You will then need to make sure that you give adequate medication prior to the scan, usually GTN, to open up these tiny little vessels so that when the contrast goes through them, you can see them. And beta blockers often if the heart rate is high. And hopefully you will get something that looks like this with nice clean coronaries. They all look normal. Or if you click again, here's an example of a patient with lots of calcification in their LAD, coronary artery. Thank you. Next. And then, of course, you've got other types of modalities that don't just look at anatomy, but also can look at function. For example, this is a cardiac MRI, and you can see here that you've got an area of hypointensity in the subendocardium, which corresponds to an area of ischemia on stress. Click again, please. This is a nuclear medical scan. So here you've been, this is a SPECT scan where you can, again, the concept is to stress the patient and then check how they do on rest and identify areas of reversible or irreversible ischemia. Yeah, thank you. Okay, so cardiovascular imaging in emergencies. If you click again, hopefully one of these will play. So you will be able to see there that these kinds of scans, which you often get on call or out of hours, most radiologists will need to know how to report these. And when you get a scan that looks like that, for example, with an absolutely enormous ascending aortic aneurysm, there's so many things to consider, but that's how it can look. And then if you click again, hopefully you can all identify what the problem is on the right-hand screen. If you can identify it now, or now, or now. Sometimes just the first look at the neck will tell you what the answer is, but obviously this is a very large type A dissection. Thanks. Next slide, please. And they take a while to get right, these things, and to be swift at them. But people will thank you for doing a good job of these, especially out of hours. Okay, here was an example where a radiologist has saved a life. So on the left-hand screen are slices from a non-gated aortogram of a patient who came in with chest pain, and they had a District General Hospital CT scan, non-gated, and you can see that everything looks a little bit hazy around the root, reported as normal, apart from a small pericardial effusion. And then you can see the panels on the right. Can you see that they're a lot cleaner? This was an ECG gated CT after the surgeon came to the radiology department, found us in our cave, and was suitably concerned there was something going on. The patient wasn't right, and they were behaving like an acute aorta. So we ended up doing an ECG gated CT where I spotted this circled area of contrast extravasation. And then you have, a conversation with them. You say, look, I think that there's bleeding coming out of the aorta. And they say no, because it's four days later now. The patient would be dead by now. If they'd had, one of these aortic leaks, we'd know about it. And it's all about the rapport that you then have with the clinicians, because eventually they were convinced and took the patient to theatre and sent me a really nice text message from the operating theatre with a picture, which if you click on, you can see. Well, with the eye of faith, that's the aortic wall, and what is circled there is a tiny hole in the aortic wall. So, that was a great win for the team, and I think for the patient as well. So, but it's a really good example of why an ECG-gated CT aorta is so useful in the acute setting. Okay, thank you. Next slide. Okay, and then obviously the heart is a moving thing, so you want to be able to see it in motion a lot. So as radiologists, we don't tend to do much echo. It'd be useful to know what you're looking at, but we're not asked to do echocardiograms. Cardiac MRI, however, we can do, and it's really useful for things like valves, cardiac motion, cardiac function, etc. Okay, next slide, please. And congenital heart disease is quite an acquired thing, and not everybody loves it, not everybody does it, but I find it absolutely fascinating. So if you play the one on the left, you will see a common, much loved exam question. So this is the kind of thing that they love to put into FRCR exams. See if you can spot the problem. So what you'll have seen on this sagittal view of an aorta, if you just go back and play the previous one, is you'll see that there's a beautiful figure of 3 aorta, which is synonymous with an aortic coarctation. And as I'm sure a lot of you know, the next follow-up question is going to be, what other abnormality can you find with those? And usually it's a bicuspid aortic valve. The one in the middle, if you play that, is actually an enormous aneurysm of a coronary artery. And then the coronary artery itself, which looks huge compared to how it should look, more like the caliber of small bowel, is actually just if you see a coronary artery look like that, you can bet your bottom dollar it's going to be a fistula between a coronary artery and a cardiac chamber. And then I just put that last one there on the right, which is a very cute quadricuspid aortic valve, which obviously should be tricuspid. Okay, next slide, please. Okay, then there's the weird and the wonderful stuff, which you can image in different ways. So if you had a CT like this one on the left, which wasn't even ECG gated, it was just a standard CT thorax. And this was a great pickup from one of the other team members. And you can see that the coronary arteries look like big sausagey things rather than the small, thin vessels they should be. And if you image that on FDG PET, they light up like a Christmas tree. So this was a great example of sort of pericoronary arteritis, and it was eventually found this patient had Erdheim chest disease. If you've not heard of that, you might want to read that. Next slide, please. So what does the future look like? Well, even after all of these interventions and medical therapies coming forward, ischemic heart disease is still the world's biggest killer, so there's still a lot to do. Better scanners like photon counting CTs are going to change the face of coronary artery imaging. You can see how beautiful those pictures look on the right. If you've got a standard CT scanner, the streak artifact from the stent will never give you an image that crisp, but hopefully in the future this will come into fore. AI automated measurements will improve shortened protocols, and they're already doing a lot for us in terms of LV volumes, etc. And if you want to get involved, my tips are to just start early, and whenever you hear of the possibility of an ECG-gated CT in your hospital, then there's the potential to do cardiovascular imaging projects. Join a society like I did, like the BSCI or the BSCMR, or if you want to go international, there's the SCCT or SCMR. And then there's lots and lots of learning from each of those societies available online, like the BSCI Moodle, which will even have a level 1 cardiac CT course for its members. And just get used to looking at the heart in other scans of the thorax. You will have endless scans of the thorax. It always amazes me how many people just ignore the vital organ in the middle. But do look at it, because the more you get your eye in, the more you'll recognize what's abnormal. Thank you very much.
Sure. Why don't we take a few questions if there are any from... No. If there are any from anyone. Just have a look in the chat. So I think, yeah, I had one question actually for you. There's lots of different accreditation options sort of available within cardiac imaging. And I suppose it was whether you felt that any are absolutely essential as a radiologist, and which ones you would recommend.
That's a great question. For radiologists, this didn't used to be a thing at all, and it was really so that the cardiologists could demonstrate that they could report at the same sort of level as a radiologist. Nowadays, because so much of it is shared, and the cardiologists tend to sort of ring fence cardiac MRI, etc. It can be harder to break in unless you've got some accreditation yourself. There are all different kinds. I mean, they're all equitable. So you would just, what I did was find the one which required the least amount of cases, and I think that's still the BSCI. It does have a strict set of rules, but they all do. Ultimately, for a radiologist who practices cardiac imaging, the aim is just the piece of paper, because we know that you're actually going to be practicing. So as long as you're doing it regularly and you can prove that you've got the cases, that shouldn't be a problem. There's some courses out there that will basically give you about 250 cases, I think. So another way to do it would be to do the course and then supplement that with, I think, something like 25 additional cases that you've supervised in the hospital yourself. So there are different ways of going about it, but and it's not entirely necessary, but it depends where you end up having to work, basically.
Great, that's really useful. There's just a couple more questions, then we'll let you get on with your talk. So one of them was, let me just scroll up, so a lot more have come through. Our cardiologist reports still need to be validated by a radiology consultant.
So the extra cardiac findings should be looked at by a radiologist. Yes, that is the case. We wouldn't double report the cardiac bit, but we certainly would be involved in looking at the extra cardiac findings.
Yeah. And then the other one, and I think maybe you're slightly biased, but do you recommend routine ECG gating on acute aortograms, and is a plain scan always mandatory?
So two different things there. The ECG gating on the acute aortograms, I do recommend that, and the guidelines by the BSCI recommend that too. And all trusts should be doing it. The logistics of it is a bit more tricky because often you'll have radiographers who aren't trained to do ECG gated CTs. But the rule is that in a query dissection or acute aorta, you should be gating the scan. Yes. For the plain CT, it depends what the question is. If, for example, the question is this patient has had, frozen elephant trunk surgery, is he bleeding? You would definitely need a pre-contrast CT. For dissection, same. You would normally do that. For like routine aortic aneurysm follow-ups, you wouldn't, for example.
Yeah.
I can read them here. Do you think cardiac CT be taken over? Do I think cardiac CT has been taken over too much, maybe, by cardiologists in the foreseen future? I think I don't look at it like that. I think cardiology and radiology work well together, and if that's really the way you start, things will go well for you. It can be difficult sometimes because there will be old feuds in hospitals that have been started by people who've come before you. But if you try and keep an open mind, actually, I find it much better to be working with the cardiologist. There's more than enough work to go around. And it's so great to be able to turn around to somebody in the room and say, you're a cardiologist. Do you think this is significant? Is this something you need to see now? Does it need a PCI? These are the things that you really should be able to have a conversation about without any awkwardness. So hopefully that's not going to be a problem in the future. Any specific courses or accreditations for nuclear cardiology? We're going to organize a nuclear cardiology study day in the coming months. So look out for the BSCI course. There's also a pre-conference day course for nuclear cardiology as well. So do come along if you're interested in that. It's in Leicester on the 2nd to the 4th of April.
So again, thank you very much for the really kind and generous introduction. I've got some goals that I want to share with you guys in terms of what we're going to try and achieve in the next half an hour or so. I'm going to give you an overview of Paediatric Radiology as a subspecialty and give you an oversight, or an insight rather, into the day-to-day working life of someone like me who is proudly a pediatric folk. And then hopefully toward the end, you can ask me some questions and then you can get a feel for what it might be like if you make potentially one of the best decisions of your life and choose peds. So as mentioned, I started life as a surgeon. I went through all the medical school thinking I'm going to be that surgical person. And I had a great time for a few years, probably loved it. This is a shout out to Scrubs, by the way. It's not on TV at the moment, but it used to be, and it was amazing. And then I got pretty fed up. So I was a general surgery registrar for a few years, and I was decent. I could do laparotomies with the consultant in the tea room, that kind of thing. I was pretty good, but then I just got fed up, got pretty burnt out, I'd say, and started feeling a bit disillusioned with medicine. I thought, should I do GP? And all these things that just go through your mind. But I thought, hold on, who's that person in the corner of this MDT that I come to every week, as in the radiologist, who looks happy, hydrated, been on holidays, and just enjoying life rather than me, who was feeling a bit miserable at the time, actually. So I switched to radiology. Again, this is a Scrubs shout out. If you've not watched it, you should check it out online. So I switched to radiology. I was doing that in the Royal London, which is a big training scheme in East London. It's also a massive trauma center. So that gave me a really broad radiological foundation. I did my ST1 to 4 there. And I did most of ST4 doing pediatric radiology once I decided that. And then I did my ST5 training in Great Ormond Street Hospital. And this is a shot of something called the Lagoon, which is the play area adjacent to the canteen in Great Ormond Street. I mean, can you imagine? So that was amazing. So I had an excellent time at Great Ormond Street. Excuse me. Lots of fantastic training opportunities there for me. Excuse me. And then I stayed in Great Ormond Street to do a post-CCT fellowship, specifically in pediatric interventional radiology. And at the time, it was the only training opportunity in Europe. So I was very, very blessed to have the opportunity to work there. So I guess I wear 2 hats, really. I'm very firmly in pediatric land, and I do diagnostic and interventional radiology. But actually, what does that look like day to day on the shop floor? So here's my job plan. Let me see if I can get my pointer on the go. Here it is. So Wednesdays are off. I think many consultants have a day off during the week now, but my days were a little bit longer. So as I said, I live in the pediatric space, and sometimes I do peds IR, sometimes I do peds DR, early start on a Monday, and I have a particular interest in peds trauma imaging, so I'm the peds trauma lead where I currently work. Monday is my acute peds day, so I take a lot of phone calls on the Monday from the A&E guys, from the patients who've been admitted over the weekend, and then they get their scans on a Monday. So I have an ultrasound list on Mondays, on Monday mornings, that's inpatients, outpatients, and then anything peds, anything hot peds that comes through the door, and that's for me on a Monday. Tuesday's an IR day, so I have a team meeting on Tuesday morning, and then have a GA list with lots of peds GA cases for IR. And then we have the general peds MBT in the afternoon, and this is all comers, all body parts. A bit of an SBA where I do lots of admin and stuff, and then some cross-sectional peds reporting in the afternoon. Wednesday I do other things. There's a big urology meeting on Thursday morning, so we've got quite a big geographical footprint in terms of us being a peds urology referral center. And then Thursday mornings, after that, I have a peds interventional radiology telephone clinic. So patients where I have intervened, then I speak to them on the phone 6 to 8 weeks after their intervention, check on them, see how they're doing. Or if I haven't got many patients to see in clinic, then do some plain film or cross-sectional reporting. More ultrasound in the afternoon. So if you like, you have to love ultrasound to do peds. It's scanning all the time. And I do a lot of interventional patients there as well, meaning that if there's someone who's got a vascular malformation and I'm thinking I'll potentially do a sclerotherapy treatment for them, I'll see them in that Thursday afternoon session, go through the pros and cons, potentially do a consent, and then line them up for a procedure in a few weeks' time. Peds oncology is where I work as a massive peds oncology center. And for me, this is a really rich learning opportunity because we have lots of input from all the other people we need for oncology. So oncology and general peds and the physios and all the people that plug into the oncology services. And Fridays, peds surgical meeting, so I run that. And also I have a peds floral list. So actually my week is pretty varied. And there are other MBTs that I regularly contribute to as well. So we have the lymphatic and vascular anomaly MBT. So as an interventionalist, I do the procedures and also contribute to the ones that are more complicated that we need to discuss. I'm part of the IBD and the ENT MBTs as well. So quite a varied list. And I'd say the best thing about pediatrics is the variety that I see in my working week. And without exaggerating, I could be involved in assessing, scanning, double reporting, something related to all of these body systems, all in the same week. And what I hope to do is give you some cases toward the end of the presentation to give you a feel for how that would pan out in real life and how you have to constantly connect the dots. Okay, there's a neuro thing, but actually what is that neuro thing connected with? Is that something like the foramen of Monroe? Does it look like a Sager? Could it be tuberculosis? Actually, let me arrange an ultrasound scan. We're constantly flicking between body system to body system, modality to modality. It's just a super fun way to spend your week if you like variety. What else do I do during my working week? I blow lots of bubbles. You know, I've got no shame in saying that. I blow bubbles. You need to keep these kids happy and comfortable. You need to gain their trust as well. And bubbles is a good way to distract our pediatric patients. Yeah, we've got lots of stickers. We hand out lots of stickers, and something really, really satisfying on some of my ultrasound lists is where you've got a kid who's got a small palpable lymph node, which even before you put the probe on, you're thinking it's going to be normal. You do the scan, lo and behold, it's normal. You give the kid a sticker. You've just given this kid a packet of joy with this sticker. So stickers are a really powerful motivator for our pediatric patients. Loads of toys, the brighter, the noisier, the better. So we play lots of toys. And it's relatively common, actually, that I'll be trying to do the ultrasound scan, and you've got the assistant who's in the room as well, shaking something or pressing a button, or they get the mum to press the button. So lots of toys, lots of interaction. Yeah, we sing songs. I think Pete is a great excuse, a legitimate excuse to keep up to date with lots of the Disney Pixar movies, because you need to know your movies and you need to know your songs. If you need to break out into, I don't know, a chorus from Moana, you can keep on top of the songs. So we sing lots of songs, keep the kids nice and entertained and comfortable and happy, because actually you may only have a short window to scan the child before they become really fractious. And actually you can completely and utterly nail a diagnosis if you know where to look. You've got the probe on the belly, you've optimized your machine correctly before the child starts to completely lose the plot and cry too much. So sing a song. And I've got a TV on the wall in the scan room where I do my scans as well. A great distraction tool. And these are all things that help to create a fun vibe in the scan room. I have lots and lots of clinical interaction with lots of clinical specialties. And again, without exaggerating, I might see all of these different specialties and interact with them during my working week. So as I said, I work at a massive oncology center. Neonates, bread and butter, one of my particularly favorite areas of peds neonatal stuff. This is orthopedics as well. So it might be the acute orthopedic stuff, so a SUFI or osteomyelitis, something like that, or something a bit more chronic. We regularly speak with the orthopedic team and arrange the imaging that they need. We've got a big gastroenterology unit where we work, and with the IBD thing or feeding tubes, speak to the gastro team all the time. As I said, I wear an interventional radiology hat, which means that a lot of the stuff that I do is under general anesthetic. Sometimes it's in the IR lab proper, or often it's actually in the operating theatre and having to liaise with the wider theatre team. So that would be the squad nurses and the duty anaesthetist, the anaesthetic registrar, all these things to try to facilitate an operation under GA. The general surgical team, surgery and radiology, we work hand in hand all the time, isn't it? So speak to the surgical team, I'd say several times a day, actually. Again, we've got a massive pediatric infectious diseases unit where I work, and all the weird and wonderful and the tropical and the rare. So I see lots of that. Again, a really rich pathological base where I can really get my teeth into some hardcore medicine. So my wider IR team, of course, and then the intensive care unit for the children who are particularly unwell. So hopefully I'm painting a picture for you of a subspecialty which is massively diverse. I would go as far to say the most diverse out of all of the radiology subspecialties, and intensely stimulating, because I could go from a 24-weeker preemie to a 19-year-old who stayed under peds because they've got a congenital abnormality, who is taller than me and weighs 100 kilos. The range is phenomenal. So really, really diverse and really, really stimulating. As I mentioned before, I work head to toe. I do a bit of neuro, some chest, some cardiac, some MSK. Literally everybody is part of my working week. And I work across all different modalities: fluoro, ultrasound, MR, CT, Every way that you can image a child is part of my working week. Perhaps not primarily reporting. For example, I'm not a nuclear medicine person. However, there'll be patients that would come to me for their initial scans, would recommend a nuclear medicine scan, and then review some of the nuclear medicine as part of an MDT, for example. Lots of clinical collaboration, as I said on the previous slide. I see these folk every working week. And as a PEDS person, I think you add quite a lot of value because at the moment, there is a shortage of pediatric radiologists across the country. I'm desperately hoping, maybe even one person on this webinar might consider doing PEDS. So there really is a need for it. And what it means is that if you've got some PEDS knowledge and expertise, you are a really valuable person in the team, be that in a pediatric tertiary center or in a DGH with a PEDS interest. You will add a lot of value. You will bring a lot to the table. I think it's really high impact work, meaning that you're helping to treat patients who have got their whole lives ahead of them. And that can be very, very rewarding. And lots of patient contact. As I said, ultrasound and fluoro, very, very patient-orientated modalities. So I've not called these things pros and cons because I think it depends on how you look at it really, but I'll put them on the other side of the screen. So parents. Sometimes you can have these challenging conversations with parents. And I think that's fair enough because actually they have presented to you their gorgeous little, I don't know, let's call her Charlotte, who needs your care and undivided attention. And there'll be lots of emotional overlay that comes with doing that ultrasound scan. It can be quite intense in the moment. The flip side is that it's actually an opportunity to have these really rich, potentially reassuring conversation with parents as well. So it depends on how you look at it, but you have to navigate the parental space as a pediatric radiologist. And it can be emotionally challenging from a parental point of view, but also from the patient point of view as well. As I said, I work in a pediatric oncology center, and I'd say most weeks I come across a child with a cancer, and that can be difficult. So I'm a parent, and particularly for people who are parents, that can be challenging. It can feel a bit close to home. And there are limited options for private work compared to other radiological specialties. So again, something to consider with pediatrics. And yes, there is crying. Now I think of it as soothing with the crying. It doesn't really bother me anymore. It's kind of white noise in the background. But if you're particularly triggered by crying, then that's something just to consider. So I said a lot. I'm going to show you some cases. And I hope, I've got a few more, yeah, I'm not doing too bad for time. I hope to show you the depth and the breadth of the kind of stuff that I do. Anna, can you just confirm that you can still see the screen?
Yep, we can see the screen with different cases.
Lovely, great.
Yep.
So I'm going to show you this baby. This baby's Prem, 28-weeker. And I wonder if anyone has already spotted it. But this baby is in bad shape. But there is a ton of free gas on this one. Continuous diaphragm sign. If you look really carefully, actually, you can see this thing here. Fast form ligament sign. All of this liver looks way too dark. So this is the lucent liver sign. And this is Wriggler sign. You can see both sides of the bowel wall here really, really clearly. So this is a preemie baby who's got large volume pneumoperitoneum. This ended up being secondary to jejunal atresia and then a perforation. So I'm going to work my way up. I'm going from the really, really small babies, neonatal stuff, bread and butter, and then hopefully, if we've got enough time, we'll pick up on some teenagers. So we've got the really, really young kids. You can see this film within 5 seconds, accurate diagnosis, jump on the phone, and then have a meaningful impact on this young baby's life. I've got a different kid for you, day 1 of life. Let me roll through the stack. And I wonder if any diagnosis might start flicking through your differential brain. So again, this kid is day 1 of life. Something's not quite right. We're seeing too much polypoid dilatation. That looks like a ureter to me down here. Let's go back up and look at the bladder. Back at the top, back at the top. So I'll accept that this bladder is collapsed. That is true. But this bladder is so thick-walled that it almost looks like a soft tissue mass. There's too much bladder going on here, way too much. And I know what you're thinking. Is it a boy? Is it a girl? I'll tell you, it's a boy. Again, still day one. So just imagine how awesome your working day could be. You've gone to prep, you've logged on, you've checked a few emails, you've seen that first x-ray. Oh, perf, get on the phone to neonatology. And then urology come to knock on the door. Oh, we've got this baby. Can you just do a scan for us? Do your ultrasound scan and said, oh, I think it's fluoro time. Let's find a slot to do a fluoroscopic study in the afternoon. So here's a control. Just want to see what happens. You put some contrast in, immediately the contrast just flicks up into the Pope-Kelly-Seal system on the right-hand side. So good going for psychoteric reflux with just a few moles of contrast. You work your way down the rest of your study. Look at this bladder here. Look how trabeculated this bladder is. And then when the child pees, we, team radiology, have made this diagnosis. Child has got bilateral hydronephrosis and reflux on one side. And what's going on? The reflux is caused by this thing here. This is posterior urethral valves in all its glory. A dilated posterior urethra, we've got a filling defect here, and then a normal / small caliber anterior urethra. Posterior urethral valves. Hello, urology, I've got a customer for you. Operation, please. I'm still not even 1 week of life, and we're just rattling off these diagnoses. Let's look at this baby, day one of life. Anna, just keep an eye on the chat for me. I wonder if there's anyone who knows in the chat who can give me an acronym diagnosis for this baby. I'm going to give you 3-4 seconds. In the meantime, let me paint the picture for you. So let's look up here. Jump on the chat, guys, see what you can find.
Yeah, somebody's saying Bactral.
Oh, somebody would be correct. You get the first sticker. I'm handing out virtual stickers today. So look at this thing, replogal tube. It's got an interrupted, fenestrated, or interruptions in the radiopaque line. That's not an ET tube. This is the esophageal pouch. That's an esophageal atresia. But we've got gas going on in the stomach. That must mean that there's a fistula somewhere. Let's look at these vertebrae. Something is not right. There's a hemivertebrae there. There's a hemivertebrae there. Actually, if Dr. Terb was still here, she'd have something to say about this heart. It's on the wrong side. Cardiac apex is pointing over this way. This child's got dextrocardia. Look at this bile gas pattern. Something's not right. And that's because there is a solitary hypertrophied kidney on this right-hand side, filling the right hemiabdomen, displacing the bowel loops to the left-hand side. And I have a question for everyone on the team. Where is the left leg? Where is it? Where's it gone? Because you've got the femoral head here. You've got enough of the left hemipelvis to show where the femoral head ought to be. This, you can just about see it. It is a very, very small, atretic, dysplastic looking left leg. So this child has got the full house of Bactral. Again, I'm only 1 week of life. Look how many diagnoses that we've gone on to. I've not even had lunch yet. So let's go to this one. So we can look at some congenital abnormalities. So you're right in thinking that with this child, the antenatal scan was abnormal. And let's work our way through and see what we can see. I'll give you the whole stack. So this child's currently 1 year old. So far we've done some GI. We're going to do a bit of chest. We've definitely done some GU. I showed you posterior urethral valve and some reflux. I'm working my way down to it. I tell you what, let's park here. So you're thinking, all right, I see you. There's a feeding vessel there. Yeah, I've got that feeding vessel. So sequestration. Well, let's look a bit deeper. But we've got cysts. We've got cysts. So hold on. We've got a feeding vessel. Let's come back down to it, coming off the aorta. So that sounds a bit like a sequestration. Yeah. But then we've got cysts. But actually, this is something called a hybrid lesion. hybrid lesion. So it's a congenital lung anomaly with features of sequestration, like we're seeing on this side, an aberrant feeding vessel coming off the intrathoracic aorta, and pulmonary cyst as well. So this is a hybrid lesion, So this child's a 1-year-old. Let's do something a bit more acute now. So imagine you are not even necessarily a pediatric, you are the SD3 on call, you work in a DGH, and A&E calls you, telling you that they've got a child with abdominal pain and they're drawing up their knees, they're 2 years old. I wonder if anyone in the chat is thinking what this might be.
The interceptions in the chat.
Ooh. Quick off the mark. I love that. I love that. Fire the answers at me for me. That'd be great. Let's see as much wonderful, glorious peas as we possibly can. This picture interests me because we've got Doppler flow preserved. And that's interesting and important because I've got some viable bowel here. This one, let me give you a few 2A things. This is the target sign. So I'm looking at this interception in the transverse view. And I wonder on the chat what we can see inside the interception, which potentially are acting as lead points.
I think somebody's written LN, so I think we've got a few lymph nodes.
I think we've got lymph nodes as well. Look at that little cheeky fatty hilum just there. So loads and loads of lymph nodes. Something that perturbs me a little bit about this interception is that I've got a little bit of free fluid which is trapped within it. So this is implying some chronicity. It's been going on for a few days. Well, not a few days, at least a few hours. So that tells me, am I going to reduce it? I'm not sure. Some fluid is squeezed out. Oh, let's see what else we can do. There is a sign on this image here. It's a longitudinal image of this interception. This sign's got a name, and I'm drawing around the edge of it for you.
Somebody has pseudokidney.
Pseudo. You guys are on fire. High five to the virtual audience. So we took this kid round to the fluoro suite, and I'm going to let this thing play. I've called the radiographer. I've got them on board. I have, as a consultant, I've got one of the juniors who's on to come and help me and try and learn from this. We've insufflated some air per rectum, and there is currently a battle. Interception versus radiology. Interception versus radiology. Where we're going to go with this thing. Hopefully you can see with the eye of faith, there is a soft tissue density here. And then eventually we see a whoosh of gas, which is reflux through the ileocecal valve into the small bowel. I'll let it play again so that we can catch it now that we've seen it all through once. So at the moment, the catheter is in the bottom end, and we are waiting to see whether or not we're going to be able to reduce this interception. So keep your eye, the flow of traffic is going to be in this direction. Oh, here it goes. There's the gas, there's the gas. We are around here now. This thing, that's the density of the soft tissue interception. So this has gone all the way around from the ileum through the ascending colon down to the rectum. And you often get a bit of a fight here, meaning that you've got this edematous ileocecal valve through which you're trying to push the terminal ileum back through. And look, radiology has won the battle. The whoosh of gas in the central bowel loops tells us that we have successfully reduced the interception. Really good fun. So I'm on a 2-year-old now. And let's think about, I've neglected the bones. Sorry, MSK. Let's have a look at this one here. So this is a 4-year-old, had some very kind of hip pain. They've got some private insurance. They went to a chiropractor. Chiropractor quite astutely said, maybe it might be the hip. I wonder on the chat, fire some differentials at me. I'm going to paint the picture while you guys think about what it might be. So it's relatively well defined. It looks, I'd say, non-aggressive and narrow zone transition, a bit of fascial widening. It seems to be limited to the metaphysis. Again, non-aggressive, they're a kid. So your non-aggressive differentials in a kid are going to be different to your, well, I should say there will be some additional ones compared to into the adult space. So we did an MRI scan, and that slice alone will give you the diagnosis. Anna, anyone on it? Anyone jumped on
Yes,
it?
there's a good differential here, fibrous dysplasia, enchondroma, and then ABC in the same result from one person.
Nice differential. You've been reading that Chapman book. Love that. And hopefully I can convince you that there is a fluid level there, because we've got the more dense blood, which is layering dependently, giving a different signal change. So this is a good example of an ABC. So what have we done? We've done some GI, we've done some chest, we've done some GU, we've just looked at a little bit of MSK. I feel some neuro coming on. I feel some neuro coming on. Again, this is all fair play, Pete. I'm not a dedicated neuroradiologist, but I might be called to look at the initial CT head that's come through ED. Then we went on to do an MRI. And I'm going to give you guys a run up. It's going to be a posterior cranial fossa mass, just while I get my alignment on the go. So maybe you can fire at me some differentials for a posterior cranial fossa mass, even before it hits your retina. Just have a think about
Glioblastoma, ependymoma.
Nice.
It's already been suggested.
What was the last one?
Ependymoma and a medulloblastoma.
Nice, nice, nice. So here we are. So let's go upstream a little bit. I'm going to choose green. So look at these ventricles, how dilated they are. We've got some transependymal edema as well. This ought not to be there. Let's roll through the entirety of this stack. This is our T2. We go down to the posterior cranial fossa. Uh-oh. We're in trouble down here. We are in trouble. So we've got this large mass, which is causing upstream hydrocephalus. Shall we look at it on the flare? Let's take a look at the flare. And then let's go down to this one here. So this is your ADC, and it is restricting. If I just tweak the windows of this one, bear with me. Yep. So high on the DWI, low on the ADC. And all those differentials were really lovely. And actually, it can be quite difficult to tell sometimes, because is it going through the foramen of Luschka? I think, yeah, probably, which would lean a bit more towards ependymoma. This one turned out to be medulloblastoma. But so long as you've got your differentials for those posterior cranial fossa masses, we can really help to guide the team here. And of course, this is a neurosurgical emergency by virtue of the obstructive hydrocephalus. Let me pick, oh, I like this case. Let me do something else. Let's go here. I'll give you a second. So I can hear what you're thinking. You're thinking subpulmonic pleural effusion on the right-hand side. Okay. Okay, I hear you. All right. What's going on here? So look at this rib, clean, crisp. What about this rib here? Can you see it looks a little bit moth-eaten, a bit loosened? As a PEDS person, I absolutely love ultrasound. So here I am, I'm scanning. This is not pleural effusion. Absolutely not. So there's something solid going on here.
Suggestion of Ewing's in the chat.
Team chat on fire. Absolutely on fire. So look at this. It's actually arising from this rib here. Something that, let me give you the chest X-ray back. Something that at first glance, if you're tired or if you've not had your morning prep, you could easily walk past that. But if I just put them side by side for you. So this is a beautiful case whereby we've really had to drill down into our plain film skills. And I think as a PEDS rad, you need to be an absolute plain film ninja, because we use plain film all the time. It's our bread and butter go-to. So actually you drill down, you find that there's a lucency there, then you say, right, let's transition to an ultrasound scan, use another modality as a problem-solving maneuver. There's no effusion there, you found something solid looking, you go over to your MRI scan and you confirm that there is a mass arising from the lower rib on the right-hand side. It was indeed a Ewing's sarcoma, so well done to whoever mentioned that. I promise you some nuclear medicine. Come on, team. Come on, team chat. I believe in you guys. I believe in you guys. It's a bone scan, just been windowed a little bit differently. So I'll give you some help. All of these things down here, this is normal physiological uptake in the physes. So don't worry about those linear things. Think about the spine. Maybe there's a bit of a scoliosis. Maybe this patient's got a bit of pain at night. Maybe it's resolved or relieved by some aspirin. Maybe. Is it coming through, Anna? I can see that.
Yeah, there's a few osteoidostomas coming through.
Nice, nice. So let's look at it on the CT. And let's go to where the money is. A bit lower down, actually. Let's find it. Let's find it. There it is. There it is. So we have got a lucent focus affecting the left pedicle. It's a bit expansile as well. And then when we go into the spec component, if I can find it. Oh, there it is. Look at that uptake. Osteoid osteoma. Team, look at us. We have done nuclear medicine. We've done plain film. We've done CT. We've done ultrasound. We've done some fluoro. We are all over this thing. It's about 4 o'clock in our working day, and we are buzzing with excitement as to the variety in our day. We've spoken to all of these different teams. We've spoken to ortho. We've spoken to neonates. We've spoken to team urology because of the posterior valves. We've gone back to ortho because we just found this osteoid osteoma. Who else did we speak to? Neonates already. We spoke to neurosurgery with a kid with the headaches. And I wonder if I've got time for, oh yeah, kids like to put stuff in their mouths. They like to put things in their mouths. So yes, it's a radiopaque foreign body. Of course it is. Team on the chat, we've only got a couple of minutes left. What are these radiopaque foreign bodies? What are they? We've got things that are not uniform in their shape, not uniform in their shape. If I can convince it that there is a radiolucent halo there, and conveniently, this one is side on. So actually, it's got a tapered edge, a tapered edge. Is it coming through, Anna?
Battery or button battery has been a few suggestions.
Yeah, button batteries, button batteries. So I'd say the giveaway, and of course, kids put their things in their mouths. That's just how it goes. But actually, we can say it's a button battery, it's trapped in the esophagus, go, 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 do something right now. Or it's projected over the ascending colon, it's gone through the GOJ, it's gone through the pylorus, it's gone through the ileocecal valve. Those are your main sticking points. So now that it's presumably in the ascending colon, hopefully it will just pass in the stool. So just keep this one in your mind's eye, because this one, if you catch it in the upper tracts, it's a full-on emergency, because you can get an esophageal aortic fistula if it's wedged in the mid-esophagus, and then you can exsanguinate and die. So we have to be able to pick this up with this radiolucent halo. It's going to look a bit different to the one I'm about to show you, which is this one. Radiopaque foreign body, yes. But look, there's no halo on this one. It's uniformly dense. So this is just a bog standard coin. Kid ate a coin. Different to this one, say, a 4-year-old Korean foreign body. So that's on one view, and then look at it on another view. This is a ring of magnets that this kid ate. And actually, although you might think it's in one solitary bowel loop, they are in adjacent bowel loops, but they're all stuck together because of the charge. And the concern there is that they can cause enterofistulas, as in fistula between those adjacent bowel loops, as the magnets pull together. So that's a surgical emergency as well. So called this one, the kid was taken to theatre. And actually they could already see that it was starting to erode through the bowel wall, but hadn't gone all the way through. So again, team radiology with our paediatric hat on has helped to positively impact the life of this child. So I'm going to go back to my presentation. I showed you some stuff. So summary, it's so stimulating and it's so diverse. I don't have not one boring day because I speak to people all the time. I see patients all the time. and I'm flicking across modalities all the time. I'm constantly having to think, could it be this? Could it be this? I don't really get into a routine of just another one of those. I'm constantly thinking. Can work anywhere. You're very, very versatile and very useful as a peds person. Patient contact for me, I'm quite a sociable, gregarious guy, so I love all the patient contact. The parents, I'd say keep an open mind. Yes, there are parental challenges, but actually I've had some wonderful conversations with parents who've just said, thank you so much for your time and attention. You've really given me peace of mind. Now I know it's normal. You get that feedback as well. So think about it both ways. There is some emotional overlay. There's no doubt in that. You're dealing with vulnerable, fragile children, but I view that as a privilege. Private work, take it or leave it. It's something that you need to just be aware of. But for me, my working day is joyful, and I'm genuinely living my best life as a paediatric radiologist. Thank you very much for your time. That's my email if anyone wants to fire an email at me. And I'm also on LinkedIn. Got some social media things going on.
Okay. That was brilliant. Thank you so much. Is it okay if we put a few questions to you here?
I'd love to. Yeah, please.
Yeah, so somebody in the chat has said, thank you, amazing presentation. Is it common to have IR and diagnostic specialties? Can someone do MSK diagnostic and IR? If yes, do you still need to go through the diagnostic pathway or IR run through?
Oh my words, that was 4 questions in one. I'm not sure if I fully understood the question. So if that person wants to do MSK, but then wants to do MSK intervention, I suppose you'd still be an MSK person, because I know there are lots of MSK people that do joint injections, bone biopsies, that kind of thing. If you mean MSK and peds IR, that might be quite a stretch, and then you would need to do, I'd say, the dedicated training.
Can I ask a follow-up question on that, actually? Because I was going to ask a question about intervention. So you did a fellowship in pediatric intervention. There's the other interventionists, pediatric interventionists in your hospital. How did they go about it? In Belfast, we have 2 adult interventionists who are IR trained, who then do ped sessions. And then there's 1 diagnostic pediatric radiologist who's like an interest in non-vascular intervention, so does the more straightforward tube changes, biopsies, that sort of thing. But just wondering what way it is with yous.
Well, I'd say what you've described there is how it's done in most of the country. You've got a cohort of adult IRs who will do some kids depending on the age of the child and the complexity of the case. And I strongly support that model, because there literally aren't enough training opportunities across the UK to then produce 300 peds IRs in the next 5 years. So we need adult IRs who will do some peds IR, absolutely. And I think the things that are super complex probably should be done in peds IR centers. And then again, the diagnostic peds people who will do a large pleural effusion chest drain, or biopsy a large mass, or drain an appendix collection. Absolutely, yeah, please do that. And I think you'd have to work collaboratively with other people. So you need the pediatric surgeons on board to say, I'm the diagnostic person who's going to drain your appendix collection. Equally, you need your peds diagnostic people on board if you're going to be the adult IR who's going to do a bit of peds stuff. So it's all about collaboration, but I would strongly support that. There has to be that crosstalk between the people who aren't specifically peds IR trained, because the numbers of that are so small, but there are millions of kids who need our help.